So first we're going to start with drug regimen review. And right about this point, I could use a few. And I'd even share. Of course, someone would have to go and get them for me, because I'm not going far at the moment. Okay, drug regimen review conducted with follow-up for identified issues. Can everyone hear me okay? I'm not used to having this handheld mic, so you'll have to bear with me. We covered this when I did this presentation in the past. And as we go through, I do want to call your attention to, in different areas, there is a distinct difference between drug regimen review and medication reconciliation. And I will make that clarification as we go through, because it's a distinction that you're going to need to make with your staff. That there is a difference between those two, and drug regimen review involves a great deal more. The acronyms that we have on the screen are the same ones that we've had before, so we'll move right on past those to our learning objectives. Our goal today is to have an understanding of the cross-setting alignment for drug regimen review for the 3 items involved. We'll review the intent, the coding instructions, and all the definitions for drug regimen review. We'll look at the coding instructions so that you can accurately code our practice scenarios. And we will also discuss the quality measure itself. The quality measure is an assessment-based, cross-setting process quality measure for the requirements of the Impact Act. We are looking here to see if, as providers, we are being responsive to potential or actual clinically significant medication issues when these are identified. The OASIS drug regimen review items, M2000, 2002, and 2004, are the foundation for the cross-setting drug regimen review measure, since no other post-acute setting had items or measures like this. And we should not infer from that these other providers did not do an active intensive drug regimen review. It was simply not being measured. So changes were made to the home health drug regimen review items so that we could have standardized items all the way across all the settings. Here you can see the dates for implementation for each of those measures across the PAC settings. We began ours January 2010, revised it for January 2017, and then the LTACs did it 7/1/18, skilled nursing facilities 10/18, and inpatient rehab on 10/18 as well. So that brings it now, everyone is doing it the same way, and we will have our final changes, we hope, implemented in January. In order for a care episode to have a favorable measure result, we need to have a completion of a drug regimen review at the beginning of the care episode, SOC-ROC. We need physician contact and follow-up if medication issues are identified at SOC-ROC. We need to have physician contact and follow-up each time significant issues are identified throughout the care episode. And that's an important thing to think about. Here's what the item looks like, M2001. This is your drug regimen review, and then 2003 below it with the follow-up. 2005 is completed at transfer to an inpatient facility, death at home, discharge from the agency not to an inpatient facility. And here it is looking at your medication intervention throughout the course of the episode. Let's consider some definitions to give background and support to this measure. Drug regimen review in post-acute care is considered to include the following items: medication reconciliation, a review of all medications a patient is currently using, and a review of the drug regimen. This includes prescribed and over the counter, items that are administered by any route, and does also include TPN and oxygen. So I'm going to go off script a little bit here. Every time I do this, there's guaranteed to be somebody who says, oh, come on, over the counter? What difference does an herbal remedy make? A lot. In 1998, my daughter was diagnosed with Hodgkin's disease. She was in the process of her chemo. And she called me one day and she said, I found something that works better than any of these stupid pills, edited slightly for content, and I'm going to try that instead of this medication for the throwing up. I said, what is it? She said, it's an herbal supplement, and the girl that's in the chair next to me when we go for chemo, she's using it, and she feels much better. I said, oh, I think you better talk to the doctor first. No, I'm fine. I won't see him for another week. I'm going to take it. She took it. Her blood work tanked. St. John's wort does not mix well with the chemo for Hodgkin's disease. She did more damage in a week than she had done in the previous month. And so big signs got posted all over that infusion center about not taking herbal remedies. People don't understand. Lay people, patients, their families, they mean well. They want to feel better. But that's an example you are free to share and get your staff to understand how critically important it is that they get every single thing from the cupboard, from the back of the fridge, from under the rocker that your patients are taking, because it is potentially interfering with your plan of care in ways that you may not know. So a potential or actual issue that in your judgment warrants physician communication or completion of his or her actions by midnight of the next day is a clinically significant issue. And this is based on yours and your staff's judgment as professional clinicians. Here's a partial list, anyway, of some of the potential clinically significant medication issues that might occur. There's always adverse reactions, a rash, an itch, any one of the items listed with all these medications. An ineffective therapy, such as an analgesic that does not effectively reduce pain. Side effects. What about the person who's taking any anticoagulant who also happens to have an ulcer? Did you know that they can't take any single one of those over-the-counter items, the Prevacid and the Prilosec? They can't take those if they're taking Plavix, Coumadin, warfarin, any one of them, because it will interact with it and potentiate it to a potentially disastrous issue. Drug interactions with drugs and with foods. What about duplications? How many times have you asked your patients for a list of their current meds and they had both metoprolol and Lopressor? Well, you mean they're different? They just took them both. What about the ones that are missing? What about dosage errors? Transcription errors happen all the time. Watch out for what came from the pharmacy. Make sure it's what the physician really intended. And then, of course, there's non-adherence, which is a nice way of saying non-compliant, purposeful or accidental. This is just a short list, but we need to look at all of these things to be sure that this drug regimen review is actually being done. That's the difference. Medication reconciliation means take the list from the referral source, take the list from the physician's office, take the contents of the infamous brown paper bag, and everything else you find in the house, and you match them up. That's med rec. And then when they don't match, now we have a potentially clinically significant issue. So now we will do drug regimen review and take that list and get in touch with the prescribing clinicians and make sure that everything is put back in order. There's the difference. So any of these issues must reach a level of clinical significance that warrants notifying the physician or the designee for orders or recommendations by midnight of the next calendar day. Any issue that does not require this level of immediate attention is not considered clinically significant for this particular item. Here are some examples. Mr. A's list of medications from the inpatient facility instructions do not match the medications he shows the clinician. I don't know that I've ever seen a patient who's did. Mrs. W seems a bit confused about when and how to take her medications. Now there's a risk for an error. Mr. T indicates that he will not take his medications because of financial reasons. Additional examples can be found in the medication section of your guidance manual, and I'm sure that every single one of us has a list of them, because our experience tells us that there are many kinds of clinically significant issues. This is a part of our comprehensive assessment. It's the responsibility of and must ultimately be completed by one clinician, but this is a perfect example of where collaboration is allowed and can facilitate your process. Your agency policy and practice will determine how you implement it and how you document it. If portions of the drug regimen review are completed by someone other than the clinician responsible for completing the SOC-ROC OASIS, this information needs to be communicated to the assessing clinician so the appropriate response will be entered. The M20 date for assessment completed will indicate the last day clinicians gathered or received any input to complete the comprehensive assessment document, including the OASIS items. So if you do this collaboratively, in many states, in many instances, agencies are doing therapy-only cases. They have an experienced physical therapist, for example, going out to open the case. In that situation, the therapist, their scope of practice in that state will determine how much of the medication review, medication reconciliation they can do. And then they need to be conferring with a nurse so that you can have the drug regimen review and the collaboration. If anything is identified, then the nurse must go out and make a full assessment to complete that drug regimen review. But at least this way you can have the collaboration, and you may or may not need that nursing visit based on your state scope of practice, based on your agency policy and practice. We have had a Q&A on this, and with the expanded one clinician convention, would it be appropriate if a second clinician completed the regimen review in its entirety by phone and collaborated with the assessing clinician? While the expanded one clinician convention allows the second clinician to complete drug regimen review in its entirety and collaborate with the assessing clinician, it's expected that an in-person assessment would be included as appropriate in the process. Portions of the drug regimen review may be conducted over the phone and/or by a clinician in the office. Other portions of the drug regimen review would require an in-person assessment to evaluate for effectiveness of medications or the presence of significant side effects. This assessment, with or without collaboration, must be done within the required time frame, and all the requirements for a collaboration must be met. And that's what we were just talking about with the PT therapy-only admission and how you work that coordination in with the other clinician. Let's talk about contacting the physician to resolve that potential or actual clinically significant medication issue. It's up to the clinician to then communicate what they have identified. We then need a response from the physician or designee to acknowledge receipt of the information, convey the prescribed or recommended actions in response to the medication issue. Every time I do this presentation, eyebrows rise, eyes roll, and people go, and this is going to happen how? In 24 hours? Really? There are a lot of ways to reach out to a physician or his or her designee. In person, telephone, voicemail, electronic means, fax, any means that appropriately conveys the message of the patient's status and the specific situation. You can do it directly if you can reach the physician or designee, or you can do it indirectly through their staff in accordance with the legal scope of practice for the person with whom you're speaking and for your clinicians and your agency policy. Because you must have a policy that addresses this type of situation. The follow-up, this process of contacting the physician or physician designee to communicate the identified issue and to the extent possible, completing all prescribed or recommended actions by midnight of the next calendar day at the latest. Okay, to the extent possible. I've had people say, well, patient gained 3 pounds in 24 hours. I called the physician said, increase the Lasix for the next 2 days, visit and weigh and check their status for the next 2 days. Well, I can't do that by midnight of the next day, so I have to say no. No. Here it says to you, to the extent possible. You reached the physician in timely manner, you got the information, you got the orders, and you have communicated that to the patient and or caregiver. You have accomplished everything that could be done to the extent possible of that order in the required time frame. So you would answer that question yes. And you would presumably continue to follow the rest of the order out over the next few days. So that's how it's done, and you do want to be sure that you are documenting appropriately. So let's move on now. We're going to go through the guidance and practice some coding scenarios. Who can code these items? No specific discipline is identified as exclusively able to perform this assessment. According to guidelines, only an RN, PT, OT, and speech are qualified to perform a comprehensive assessment and collect OASIS data. But you do need, as I said before, you need to know what your state scope of practice is, and you need to make those inquiries. If you don't have that information, you need to make the inquiries at the appropriate level. This is M2001. We do this at SOC-ROC. Your choices are no, you've had no issues, yes, there were issues, or not applicable, the patient is not taking any medications. That does not mean they're not taking medications by choice. It means they had none ordered. For the coding instructions, we would enter no issues found, assuming that based on the clinician's professional judgment, no clinically significant issues are identified. We would code yes if issues had been found, and we had a sample list on an earlier slide. We would code 9, not applicable, if the patient is not taking any medications based on the physician's orders that there were no medications to be taken at the time of the assessment. A dash is a valid response for this item, but of course it should always be a rare occurrence. If elements of drug regimen review were skipped, for example, drug-to-drug interactions not completed, a dash should be reported, indicating the drug regimen review was not completed. There are skip patterns here, and I want to point these out. If you code 0 no issues found, you will then skip to M2010, patient caregiver high-risk drug education. If you have coded 1 yes, you're going to move on to the next question, M2003 follow-up. If you have coded 9 not applicable, patient is not taking any medications, you then move on to 2102 to the types and sources of assistance. So if you have an electronic record, your vendor should have implemented these skip patterns for you. If you are on a paper system, please pay careful attention to them. The sources of information for answering 2001 include your patient assessment. The resource for some of the definition can be found in the new COPs. Your clinical record should include the communication notes to and from the physician or any other source of information and the medication list. Another resource is collaboration with other agency staff as allowed, including review of documentation, and then you can always go to the Q&As regarding drug regimen review. So let's try this. During the comprehensive assessment to Mr. K, the PT reviews all the patient's medications, identifies no problems except the patient's pain medication is not in the home. His wife states they were only going to pick it up from the pharmacy if the pain got bad enough. PT reviews the physician's instructions for the medication, and they agree that it should be on hand and following the instructions for administration. Prior to the PT leaving, the wife has gone to the drugstore and returned with the medication. So how would you code M2001 in this case? Did the drug regimen review indicate that there were no issues found, that there were issues found, or the patient was not taking any medications? Okay. Got a little back and forth hesitation there. Oh my goodness. Oh, people are wavering. Is this an issue or is it not? My goodness. You guys are worse than the election results. I think we're going to quit while we're ahead. So back to the question, the correct answer was no. Now think about that. The answer is no because the issue did not require physician contact by the next calendar day, and it did not meet the criteria for a potentially significant medication issue. And the reason for that is because it stated before the PT left and completed her assessment, the wife had returned with the medication, understood the instructions, and would follow through. So because that occurred before the assessment was completed, that means that it was not a significant issue. During the start of care comprehensive assessment, Nurse Richard completes all elements of the drug regimen review except for checking the drug-to-drug interactions. How many times does that happen? Most of them, I think. Did a complete drug regimen review identify potentially clinically significant issues? No, no issues were found. Yes, issues were found. Not applicable, or enter a dash. Look at that. Good job. Okay, come on. Let's move on and see what the answer is. The answer is a dash. Because remember, if she did not complete that drug-to-drug interaction review, then we don't have all the information we need, do we? But that is an issue, as we all know. Nurses will sometimes forget to do that, and it's on us to make sure that that does not get skipped over. Let's move on to 2003, medication follow-up. This is how it looks in the OASIS tool. The intent of the item is to identify if a potential or clinically significant medication issue has been identified and communicated to the physician or designee, and that the actions recommended or ordered were completed by midnight of the next calendar day. The instructions for us are that for each potential or actual clinically significant issue identified, the physician or designee was contacted and the prescribed or recommended actions were completed by midnight of the next calendar day, and remember the caveat, to the extent possible. So here are some examples. A clinically significant medication issue is identified at 10 a.m. on February 12th. The physician's prescribed recommended action is completed on or before 11:59 on February 13th. Okay, the second example is that same issue was identified at 10 p.m. on February 12th. The physician's prescribed action is completed on or before 11:59 p.m. on February 13th. You would code 0 no if all potential or actual significant medication issues were not communicated with the prescribed actions completed to the extent possible by midnight of the next calendar day. You would code it yes if the communication and completion of the actions were completed by midnight of the next calendar day. And again, dash does remain a valid response, but we should have this information. You would code it 0 no if all potential or clinically significant issues were not communicated with the actions completed. I think we have a duplicate here. Okay. Yep, and we move on. The data sources in this situation are the clinical record, the communication notes, the plan of care, and the medication list. Let's try a coding example. During the start of care comprehensive assessment visit, the RN completes drug regimen review and identifies that the patient is taking 2 antihypertensives, one which was newly prescribed during his recent hospital stay, and another he was taking prior to his hospitalization. During the home visit, the RN contacts the physician's office and leaves a message providing notification of the potential duplicative drug therapy and a request for a clarification. The next day, the RN returns to the home to complete the comprehensive assessment and again contacts the physician from the patient's home. The physician office nurse reports to the agency and the patient that the physician would like the patient to continue with only the newly prescribed antihypertensive and discontinue the previous medication. Did a complete drug regimen review identify a potentially clinical significant medication issue? Would you answer no, yes, an issue was found, not applicable, or a dash? Now, I'm liking that. 100% will just look quick before anybody changes their mind. And the answer is yes, an issue was found. And with the use of generics, this is especially problematic. They come home with a script, they get it filled, and they don't recognize that you have a brand name and a generic, and you have 2 bottles with the same medication, because that's not in their scope of knowledge. But it's certainly in ours. And that's why this is so critically important. How would you code 2003? Did the agency contact the physician by midnight of the next calendar day and complete the prescribed and recommended actions? Yes, we did. And there we go. So M2001 is coded 1 yes, 2003 is coded 1 yes, because the issue was determined to be clinically significant and it was communicated and the action completed by midnight of the next calendar day. So the answer to both of these is yes. Let's look at the third one in our group. M2005, medication intervention. This is how it appears in the OASIS tool. It is completed only at transfer to inpatient facility, death at home, discharge from the agency, not to an inpatient facility. So here we're going to be looking at, did the agency contact and complete physician or physician designee recommended actions by midnight of the next day, each time the potential clinically significant issues were clarified since SOC-ROC. 2005 is looking from the time of the patient's transfer, discharge, or death back to and including the most recent SOC-ROC. So you have this whole care episode that you need now to go back and review when you are doing that transfer discharge OASIS, which truly you should be doing anyway. But this is going to be a necessity in order to answer this question. So here we have some specific instructions. The assessing clinician, alone or in collaboration with other agency staff, reviews the patient's clinical record back to and including the most recent SOC-ROC to determine if, for each clinically significant medication issue identified, the communication occurred and, to the extent possible, physician or designee prescribed recommended actions were completed by midnight of the next calendar day. So here are your coding instructions. We're going to code this as a 0 no if all of the clinically significant medication issues identified at the time of SOC-ROC or any time since the most recent SOC-ROC were not communicated to the physician or designee, and all prescribed or recommended actions were not completed to the extent possible by midnight of the next calendar day. There's a lot in there. So you need to read that code, that intent there, those instructions carefully, and break it down into its respective components. To say yes, all clinically significant medication issues identified at the time of or any time since the most recent SOC-ROC were communicated to the physician or designee, and all prescribed recommended actions were completed to the extent possible by midnight of the next calendar day, each time it occurred. Not applicable means there were no potential or actually clinically significant medication issues identified at the time of the most recent SOC-ROC or any time since, or the patient's not taking any medications during that whole episode period. And again, a dash is a valid response, but it should be a rare occurrence because we've looked at all the different sources of information and you know that they're there. You should be able to gather the data to answer the question. So again, you would code this 0 no at the time or any time since the most recent SOC-ROC. The clinician did not communicate all identified medication issues to the physician until after midnight of the next calendar day. The clinician communicated the issues but did not receive a response until after midnight of the next calendar day. The clinician did not complete all of the designee prescribed recommended actions for all medication issues by midnight of the next calendar day. When you look at the middle one, where they communicated but did not receive a response until after midnight of the next day, I see the heads nodding. I know this is an issue. You can get your clinicians, one way or another, to make that outreach, to reach out to the physician, to get the information over there. Getting the response back is not always so easy. So you really want to explore the means and how you can go about getting that information over and getting something back. You want to look at what your options are. Sending a fax that says, assuming that if I don't hear from you, this is the order. You need to do something, but you really need to focus on getting that response back. For 2005 to say yes at the most recent SOC-ROC and throughout the quality episode, the clinician communicated all the identified issues and all the actions were completed by midnight of the next day. The clinician contacted the physician or designee, and the physician or designee communicated that no actions were necessary. And all of this communication back and forth took place before midnight of the next calendar day. Third option, the physician or designee recommends an action that will take longer than the allotted time to complete, and the agency has taken whatever actions possible to comply by midnight of the next calendar day. 9, not applicable, says there were no potential or clinically significant medication issues during the entire episode, and/or the patient is not taking any medications prescribed, OTC, by any route, including TPN and herbals. As we said, the dash is valid. It says no information is available, but you should complete transfer and discharge assessments to the best of your ability when a care episode ends unexpectedly. Here are those data resources again: the clinical record, your communication notes, the plan of care, and the medication list. Here's a scenario. During the discharge assessment visit, the RN reviews the patient's medication list, confirms that no potential clinically significant medication issues are present. In reviewing the clinical record, there is documentation that a drug regimen review was conducted at start of care. No potential clinically significant medication issues were identified. There is no other documentation to indicate that potential or actual clinically significant medication issues occurred during the episode of care. How would you code M2005 on this discharge assessment? Did the agency contact the physician? No, yes, not applicable. We're thinking about it. Those numbers keep wiggling. I hear a little discussion in the background there. All right, let's see if 92% are correct. And the correct answer is not applicable. This is not applicable because there were no potential clinically significant issues identified since SOC-ROC and/or the patient is not taking any medications. There is documentation in the scenario that says the agency looked for potential clinically significant medication issues during the completion of the drug regimen review. No potential or actual clinically significant medication issues were identified at any time during the episode from start of care through to discharge. Let's try another one. During the start of care comprehensive assessment, the RN completes the drug regimen review and identifies a potential clinically significant medication issue. On the day of admission, the RN calls, leaves a message with the physician's office related to the medication issue. The physician does not return her call until after midnight of the next calendar day. No other medication issues arise during the episode, and the patient is successfully discharged from home health. So now, let's go through the series. We're going to do the whole sequence this time. How would you code 2001 on the start of care assessment? Did the regimen review potentially clinically significant medication issues? No, there were no issues. Yes, there was an issue. Not applicable, the patient is not taking any medications. Oh, look at that, 100%, yay. Oh, who changed their mind? Back they went. See, I persuaded you in a hurry, didn't I? All I did was ask a question. You need the courage of your convictions. Of course, you would have been wrong. There was an issue found during the review. Now, let's look at 2003. Did the agency contact a physician by midnight of the next calendar day and complete the prescribed or recommended actions in response to the identified potential clinically significant issue? No. Yes. Or we don't have enough information. We're a little more ambivalent this time. Okay. There we go. So let's see what the answer is, and the answer is no. And do you remember why? That's right, I can hear it. The physician did not call back. And that's Unfortunately, that lands on us. So it's on us to find ways to communicate to them that will get us an answer back within the prescribed time frame. So let's look at the third in our series, 2005. Did the agency contact and complete physician or designee prescribed and recommended actions by midnight of the next calendar day each time that potential clinically significant medication issues were identified since the start or resumption of care? Our choices are no, we didn't, or yes, we did, or not applicable. Now think about that. Go back and read the question again, and then we'll see. Oh, we've got some few people here. Okay. 90% say that the answer's no. And the answer is no. The coding on start of care was, yes, an issue was found. We did not get the response timely. And then on discharge, the answer is still no. Because an issue identified was determined by the clinician to be clinically significant. Physician contact by midnight of the next day was needed, so it met the criteria for a clinically significant medication issue, so the answer is yes for 2001. Now, the clinician initiated the communication, but the required two-way street here did not occur until after midnight of the next calendar day, which resulted in 0 no for both 2003 and 2005. And that is because when we are looking at the whole episode, we have to include the event that occurred during the sock rock as well. Even if there was never another issue identified for the rest of the episode, you still need to say no for 2005 because you have to include the incident that occurs in the sock rock event. So let's move on. We're going to look at drug regimen review conducted with follow-up look at the actual quality measure itself. The quality measure for drug regimen review is titled Drug Regimen Review Conducted with Follow-Up for Identified Issues. The measure description reads as follows. The percentage of patient care episodes in which a drug regimen review was conducted at the time of sock rock and timely follow-up with a physician occurred each time potential and actual clinically significant medication issues were identified throughout that care episode. Every quality measure has a numerator and a denominator. So let's take a look at how each of these are defined so that we can better understand how the quality measure results are being calculated. The numerator includes the number of episodes in the denominator where the medical record contains documentation of a drug regimen review conducted at sock or rock with all potential clinically significant issues identified during the course of care and followed up with a physician or physician designee. The denominator is quite simply the number of patient care episodes with a discharge, transfer, or death at home assessment during the reporting period. So we are looking at, for the denominator, qualified episodes, but the numerator definition is more complex. There are no exclusions from this denominator for this measure. This measure is not risk-adjusted or stratified. Based on the definition of risk adjustment, logically it would not be, because it's very straightforward. You did the drug regimen review, you either identified an issue or there wasn't one, you followed up with it, and you completed the actions. So there is no need for a risk adjustment in here. The items that are included in the quality measure itself are all three: M2001, the initial drug regimen review, M2003, the follow-up, and 2005, the intervention. If a dash is entered for any of these three items, the episode will not be included in the numerator count, but it will be included in the denominator account. So based on that, even somebody as mathematically challenged as yours truly can understand the impact that this is going to have on your ultimate percentage for your score. How does this get reported? We've had some excellent presentations on how the quality measures are calculated and reported. So let's take a look at this one. You've done your patient visits, your SOC-ROC, and your discharge assessments, and you've collected data here through January 1st, 2017. Your data is going to appear in CASPR no later than January 2018, and in public reporting no later than January 2019. The Drug Regimen Review Measure was adopted to meet the requirements of the Impact Act in the domain of medication reconciliation. Drug Regimen Review Items were first introduced to home health in 2010. They were revised last year in January in 2017. These items are now being implemented in IRF, LTEC, and SNF, inpatient rehab facility, long-term care hospital, and skilled nursing facility. Drug regimen review guidance has been refined so that it better aligns across all of the settings. Think about taking your patient when they're referred to you by any one of those three settings. We all need to be on the same page. It's critically important for you to know if there have been side effects, if there have been interactions, if there's a difficulty with getting a physician response, so that you can consider what your alternatives and your options might be. We need to know this. And it's going to matter to know how well we are conducting this drug regimen review in every setting, so that we can ensure that we are all communicating this critical information back and forth as we go. So now that we've done this, let's take a minute. You have your action plan forms. Think about when you go back tonight, tomorrow, Thursday, back to your office. How are you going to go about looking at, first of all, since we've had this measure for a while, how have you done? What do your scores look like? Are you and your clinicians successfully completing the drug regimen review? Have you looked at, now that we have clearer guidance on the one clinician rule and collaborating, how is that happening? What is your policy on drug regimen review? Are your staff all really clear about the difference between MedRec and drug regimen review? Do they understand the difference? What is your current practice for how you go about getting the information to the physician timely and then getting a response back? Do the people doing the discharge assessment, do they understand what it means when you say completing the action necessary to the extent possible? When they take those orders and the order extends out over 2, 3, 4 days, 2 weeks, are they saying yes or no? So those are some of the things that need to be part of your action plan. So take a couple minutes, think about what you could, would, should do. How are you going to tackle this when you go back? Because it is going to be a very important item for you to look at. And you do want to have a plan in place for how you're going to go about it. I see we have up here that not all medication problems are significant. Some of them are over-the-counter issues. As I said before, over-the-counter medications particularly some of the herbal supplements, they can be clinically significant. I know personally, St. John's wort should be totally benign, right? That can create some significant issues for people who are immunocompromised. So I personally don't want to be the one who says to the patient, oh, okay, sure, fine, you can shop the herbal aisle anytime you want, and if it makes you feel better, that's cool. I don't want to be the one who says that, and then there's a problem. Over-the-counter medications should not be considered benign. It is part of the drug regimen that the patient and or their caregiver is implementing. And so we need to include that. We could just as easily say that food and drug interactions are not, that's not really critical, right? How many times have you looked at an antibiotic prescription lately? Have you looked on the side of the bottle? I picked one up about 3 weeks ago for my husband and almost fell over when I saw they'd actually put a little red label on the bottom that said, do not take grapefruit or any citrus products with this medication. I thought, well, I'll be dipped. They're finally paying attention. It was a nice big red label. So food and drug is just as important. There isn't anything that goes in or on your patient that you don't want to be reporting, okay? It's important. The physician needs to know. Think about if you have a home health aide in a case. God help us what they might be putting on the patient. You get these herbal remedies that come as salves and ointments, and then of course there's all the lovely things you can get over the counter. There's all these different new patches for pain control. And just how much lidocaine is in that thing anyway? And did they really put just one patch on, or are you going to undress them and find 4 somewhere? Truly. So you need to know what's going on. You do need to include all of these options. Okay, we have another comment. Reviewing our latest scores. Okay, you see this, and this person has mentioned that there's patient satisfaction involved in here. Think about your HCAP survey. What does it say in there about medications? Go back to your office, pull up the survey itself, and look at the medication questions. Did the nurse seem up to date in her knowledge of your medications? Did the nurse explain your medications? Did she do medication reconciliation? They don't even know what that is. God help us, why they put that in there. But it's important. And that's why doing a nice hour-long with your staff on what medication reconciliation is as opposed to drug regimen review, why they have to include all those over-the-counters and the foods and the salves and everything else, it is important. The time frame on the physician response, you're right. This is critical, not just in a Medicare assessment, this is critical for patient safety. Personally, my hobby horse is patient safety. And this goes right along with it. If we are not getting timely contact with the physician, timely follow-up and response, and timely implementation of the order, patient safety is compromised, and I certainly don't want that on me. So we need to be really pushing to get this done. Changing your clinician education is an excellent option. Including the definitions, the expectations, and the patient teaching is a really good idea. With the new quality management process in the new COPs, look at this as a way to implement a quality project, a performance improvement project for the next 6 or 8 weeks. It's relatively simple to do, but it can have tremendous positive impacts. So that you look at your current scores, you look at your HCAP scores for all the medication-related questions. Take that data, make a plan. Take these 3 medication questions in the context of your current scores from the last few months, as well as your HCAP scores. And then when you put that all together, you can create 45 to 60-minute in-service for your staff, a staff education. Let them play it out in scenarios. Take the ones from here. Take other scenarios. Use the case study from this afternoon and pull out a medication piece from it. This will give you an ideal opportunity to ensure that everybody on your staff fully understands 2001, 2003, and 2005 the way they should. And it will give you the ability to have a performance improvement project that will improve your scores in these measures. So, do we have any other comments or questions? No? Okay. So I hope that that's been helpful. I know we've finished this session a little bit early, but I hope that, you will be able to take the information and really focus on how you can address your patient's needs and how you can properly answer this question. So if you'll all hang tight for a second, I got done a few minutes early. We've got to give Bridget a chance to dash on up here and give us our instructions for the next step.